Thank you to everyone who is joining. Apologies that we're running a couple of moments behind. This is just a reminder that you can see and hear us, but we are not able to see or hear you. So if you have any questions or commentary throughout the course of today's discussion, please enter those in the chat or the Q&A. There will be a little bit of time for that at the end of today's discussion. If you are having any technical difficulties, please feel free to drop a note in the chat to me directly as well. More than happy to help you with those at any time. We're going to give it just a moment or two to allow everybody who would like to join to get on, and then we'll get started. And for those of you who have just joined, this is just a reminder that you are coming in muted. We cannot see or hear you, but we'd love to hear your questions. You could drop those in the chat or the Q&A at the bottom of the screen for us throughout the course of today's discussion. We'll have a little bit of time for Wendy and Peter to ask those at the end of today's call. And with that, Wendy, I will turn it over to you.
Great. Well, hello, everyone, and welcome to our discussion. Our fireside chat. Today, we're going to be discussing issues around improving access for the underserved. And to start our session, I'd like to introduce our panelists and our moderator. We have a really great group of people here. So let me start by introducing Alpa Vyas. Alpa is the Vice President and Chief Patient Experience Officer at Standord Healthcare. She is responsible for developing and driving patient and family-centered programs, services, patient satisfaction reporting. In addition, Alpa has led the design thinking efforts and developed new services to advance leading edge and coordinated care. Alpa also previously served as the Administrative Director for Performance Excellence at Standord Healthcare. Prior to joining Standord, Alpa was a healthcare strategy and operations consultant with Deloitte Consulting for over 8 years. She is committed to improving patient experience and to developing effective methods of increasing access for the underserved. So welcome, Alpa, and thank you for joining our discussion today. Next, I'd like to introduce Jorge Reyno. Dr. Reyno is a board-certified infectious disease and internal medicine doctor. He is the Senior Vice President of Population Health at Martin Luther King Jr. Community Hospital in Los Angeles, where he is responsible for the establishment of value-based relationships with other hospitals, physicians, and provider organizations. Dr. Reyno has extensive experience in clinical management, accountability performance, quality excellence, and utilization management. And throughout his career, he's implemented clinical and operational protocols to work to successfully identify quality of care metrics in various disease-specific programs. And he is very committed to improving access for the underserved. So welcome, Jorge. And then I'd like to introduce Abhi Rastogi. And Abhi is the President and CEO of Temple University Hospital and the Executive Vice President of Temple Health. Temple is a leading health system and safety net hospital located in Philadelphia. He has a proven leadership record around operational efficiency initiatives with sustained outcomes. And as a safety net hospital, he spent most of his career serving the underserved. He is well known for his leadership and ability to execute strategic clinical and operational improvement initiatives. Abhi leads a number of strategic service lines, and he was instrumental in the growth of Temple's nationally renowned lung transplant program, propelling it to the top volume program in the country. So welcome, Abhi, and thank you for joining us. And moderating, and our moderator for this discussion will be Peter Blau. Peter is the managing partner for DHR Global's Healthcare Services division, and he has been managing searches and working with leaders for executive and clinical leaders for over 25 years. He's collaborated with key leaders at urban, academic, and rural hospitals and health systems throughout the United States, and he also works with managed care companies and ancillary health organizations. So welcome, Peter, and I think on that note, let's begin the discussion.
Thank you, Wendy. Really excited to be with everyone today, and thanks so much for everyone joining us from outside. So why don't we start the discussion with Abhi. Abhi, can you tell us a little bit about the population that you serve and some of the challenges you face when in trying to improve access for that population?
Yeah, well, first, good afternoon, everyone. And Peter, I want to start by thanking you and DHR Global to put a spotlight on this important topic. You know, as Wendy said, this is something I've been doing for 20 years. Temple University Hospital is located in North Philadelphia. For those of you who don't know, it's one of the most underserved communities in the city of Philadelphia. We comprise of a few campuses. You know, the main University Hospital campus is located here on North Broad. That's where I am. It's a level 1 trauma hospital, and fortunately has the highest penetrating trauma that we see on the Eastern Seaboard. We also have another hospital called Episcopal Hospital, which is primarily our behavioral health campus, and it's located right around the corner from Kensington, which is commonly referred to as the opioid capital of the country. In addition to that, we have a community hospital by the name of Jeans Campus, a Northeast campus, which is mostly ambulatory, and then our newly created Women's and Family campus, which I'll talk about a little bit more in further discussions. To give you, Peter, an overview of our community, you know, we're one of nation's most economically challenged, urban areas. We have the highest volume of population covered by Medicaid in the Commonwealth of Pennsylvania, close to about 1,000 beds, over 10,000 employees, 50,000 discharges, 25,000 surgeries, close to about 200,000 ER visits across 3 of our emergency rooms, about 400 solid organ transplants, including bone marrow transplant, actually, and about 2 million outpatient visits, both hospital as well as physicians. And as Wendy said, we're the highest volume lung transplant program in the country for about now 5 years. Our patient population is, again, like I said, this is close to home, it's underserved. 70% of our population has at least more than 2 chronic health conditions. 51% of them have a behavioral health diagnosis. 40% of them are obese. About 30% of them have substance use disorders. And the life expectancy of our population as compared to downtown Philadelphia, which is only about 5-6 miles south, our expectancy is 10 years less in men and 8 years less in women. So that gives you a picture of, North Philadelphia, a picture of the population that we serve. And when you look at all of that, the need for healthcare is even more important for this population than some of the other zip codes in our city. Our greatest challenge is, how do you engage our patients? So really what we focus on is access, affordability, as well as adapting towards improving the health of our population. It doesn't encompass just one episode, so when the patient gets admitted to our campus, but it rather is how do you engage these patients and our community to get more of a complete care, which includes follow-up testing, primary care visits, specialty visits, medication compliance, all of those things. So really to overcome, we have to learn how to structure the care around our patients and not expect them to just come to us when they need us. We need to make our patients the center. We need to modify our processes. We need to meet them where their need is. So whether that's in their homes, in their communities, it could be any of those. So that's what we're really trying to do in order to help improve care for the community.
Wow, that's very compelling, Abhi. And Jorge, maybe you can tell us a little bit about your community, which I know probably has some similar challenges and how you're overcoming those.
Yeah, thank you, Peter. And again, thank you for this opportunity to be a part of this panel. But yes, I'm hearing some significant similarities in our population. Essentially, we are serving the communities of South Los Angeles, It's about 1.3 million residents in South Los Angeles that we provide care for. And it is basically located, quite honestly, in the heart of really one of the wealthiest areas in the state and in the country. But despite that, we really have significant amount of deficits and deficiencies in our health indicators. We have an epidemic of chronic disease, similar to what I heard earlier. We also suffer from a decrease in life expectancy. In essence, it's about 10 years less than the average Californian. And so these disparities come about due to a number of structural issues that lead to really poor access in many cases. And so much like at Temple University, access and improving access is a paramount issue for our system.
So Alpa, you and I have had discussions around access in the past, and maybe you can share a little bit about some things that you're facing and some of the ideas that you have.
Absolutely. Thank you, Peter. And it's really a privilege to be on this panel with Abhi and Jorge. So thank you for the opportunity as well. And maybe just to build on what they've both talked about, access is paramount, especially for not only the underserved populations, but when we think about the diversity in age groups and backgrounds, et cetera. Stanford Healthcare serves a portion of Northern California. Our main campus is here in Palo Alto as a part of Stanford University. Again, as Jorge, you mentioned, we are in a fairly well-resourced part of the state here in Northern California, but our organization also serves through our community hospital, parts of the East Bay counties. And there's, I think, a really unique opportunity with many of us who sit within the academic medical centers of how do we really think about creating access not only to primary care, but really the specialties and the subspecialties that many of our patients who are dealing with chronic diseases that manifest then into potential longer-term health issues. How do we kind of create the networks and the partnerships to create access to that specialized level of care that many of our organizations focus on. But just in terms of size and scope, we're a mid-sized academic medical center, like I said, with our main hospital here on the Stanford campus in Palo Alto. We have a community-based hospital, which is our Tri-Valley Hospital. We have both a faculty practice, faculty that practice through our School of Medicine, and a community physician practice that is really kind of spread across the entire North Bay. Just some statistics around, just as I'm sure with what Abhi and Jorge can talk about, very diverse population here in Northern California. I would say 70% of the population in the two major counties that we serve here in Palo Alto are non-white. And the demographics from that perspective just kind of point to, I think, some of the opportunities that we're going to talk about later in this conversation. And from our health needs assessment, the things that we see here in our region are the impact on healthcare and access as it relates to homelessness, access to behavioral health, some of the chronic conditions that were already mentioned. And even though the economics of the area are sound, the economic instability and disparity amongst the populations that we serve, I think, are fairly significant.
Well, Alpa, I want to kind of feed off something you said earlier about extending out in those specialty areas. I understand you're doing some interesting work there to provide access to those specialty areas for underserved populations. Can you talk a little bit about that?
Sure, and I'm sure the conversation around how to leverage technology to extend care may come up, but I think one of the major ways that we're trying to think about this and just experimenting in the kind of creative ideas that we can come up with. from the technology front, really thinking about how do you extend specialty and subspecialty care through the partnerships and the networks that we have. So for example, the physician-to-physician consults. So saving a patient time from taking time off of work, arranging transportation to get specialty care. There may be opportunities to do things like e-consults. We are trialing a lot of that internally. Extension of telemedicine services is also something that we are continuing to invest in. And then the third piece, I think, is good old-fashioned partnerships with the community providers and the community partners that are developing trusting relationships with the underserved population. So how can we be in that fold and kind of meeting patients and communities where they are?
Right. Jorge, I know you're doing a lot of work around telehealth right now. Can you tell us a little bit about that?
Sure. I think the work about telehealth is, and what we're doing with it is really one of the components that we have to try to improve access. I think there are assumptions that often occur for underserved communities, and that they are not necessarily technologically literate. However, we find that most of our patients, despite being in an area that is experiencing high levels of poverty, high levels of unemployment, which is contributing to the high levels of poorly treated chronic disease, remain technologically literate and often do have access to devices. Therefore, telehealth for a subset of those patients has been a great way to try to expand the reach. And that's only one component, and that's along with, it has to be a sort of a multifaceted approach. Also kind of going out to where people are, going into people's homes, both physically and virtually. And so that outreach and that sort of engagement is really key, we find, to improving some of the access needs of many of our patients.
Yeah, Peter, I just wanted to comment on what Jorge said. So our social determinants of health surveys that we've done, and we've done about 50,000-60,000 of those when patients come into our EDs and clinics and ask them about, what are their challenges. You'll be surprised to know that only 7% of them have indicated some sort of, a gap in technology. And 93% of them have some connected device that they can use. And in fact, I agree with both Alpa and Jorge. If you start to create more telemedicine services for them, I think they accept it. They also communicate through the MyChart. We have Epic here. They communicate through the MyChart application too. We have some phenomenal numbers of 60,000-70,000 message exchanges between providers and patients, and a turnaround time of about less than 2 days. But most importantly, the telemedicine visit no-show rate is about 50% less than an in-person rate. So I think, we definitely need to leverage the technology, because this population has housing issues, transportation issues, but not technology issues.
Okay, that's interesting. Are there ways for that 7%, which I guess is like, the really difficult folks to reach? I mean, are there ways, to engage them and ensure that the technology is available in an equitable way?
Yeah, so sorry, I'll just take that if you don't mind. What we've been able to do is we obviously don't want to just ignore that population. So we created something in the city of Philadelphia, which was called Vision 20. And this was just leaders of different organizations, healthcare and non-healthcare, coming together to address the needs of the population when it comes to access and healthcare. And so for those 7% of the populations, we're thankful that we have Comcast, Xfinity in our city with their headquarters here. So we were able to leverage their expertise and their resources to create either, hubs or give out devices and try to make sure that we expand that connectivity to these patients. So, great question.
Thank you.
Peter, if I could build on that to what Abhi said, we find that those that sort of fall out in terms of having limited technological access is not necessarily because somebody in the household doesn't have access to a smartphone device or a computer. what we have found, at least in our areas, that there are pockets of what we call broadband deserts, essentially. And people in these areas are very savvy in trying to find where can you find Wi-Fi access and so forth within their community. But to even try to get around that, we've invested into some devices and so forth that people can take home for remote patient monitoring that come along with a wireless router, essentially, so that they can connect with the cellular services and obtain that sort of broadband access. So again, yeah, we have to attack these things from a multimodal type of approach, because the challenges can be very deep in communities like this.
And maybe, Peter, just to round out to what Abhi and Jorge have already talked about, which are amazing programs. One of the things that we've been thinking about, at least from the lens of patient experience, is that patients and family members may decide to communicate to us in different modes and channels, depending on where they are in life or whatever circumstance may be around them. So even some of the less technologically advanced methods of communication have also been a great kind of connection point with our patients. So our nurse advice line that we have activated after hours for patients, I think has been a really useful connection point to help avoid potential ED visits. It's a first line of communication. We have the ability, like I think many organizations do, to bring interpreters online as well, and even convert to a video visit should they need to get a broader kind of physical assessment of either the environment, a wound, whatever the issue might be. So the notion of having to leave their home or wherever they might be to come to the emergency department, which again can be expensive and incur additional costs, perhaps we can address their health need exactly where they are through a more traditional mode or method, but having the flexibility to bring in other advanced technology if needed.
Yeah, Alpa, you probably see the same thing, right? It's not only the patient himself or herself, it's also the family members, right? We hear the same things. Well, I couldn't come to my appointment because I didn't have a caregiver for my parents, or I didn't have a babysitter for my kids. So I think it's all of that. So if we're able to deliver the care to this community in their home or in their community, I feel that we'll have a better chance of engaging them.
That's a really great point, and I'm glad you bring that up. Yeah, we seem to have a significant no-show rate, higher than in other communities and higher than other experiences I've had. And it's exactly as Abhi said. It's people don't intend to not make their appointments. It's just, what are the circumstances of that day? And there are a number of circumstances that often occur that are barriers, as mentioned. Transportation is not available that day. There's somebody else in the household that has a higher need that particular day. There's a number of things that are barriers to care that don't exist to the same degree in other communities.
Build on something Alpa briefly mentioned, and maybe Jorge, you can share some experiences on this. I mean, how do we engage, community organizations and local stakeholders to help to provide access?
Yeah, that's a great question, and I think community stakeholders, community influencers, and various community members are key to try to promote engagement. And I heard a couple of times, go where people are, essentially go to them. And that's something that we believe in wholeheartedly. So we partner with various organizations that are in the community that have basically a similar mission or want to obtain a similar outcome, whether that's increasing health literacy, whether that's facilitating care, or whether it's just providing health screening and information to our patients. We do so by partnering in one way we have 9 barbershops in our community that we partner with. And every week we're at a barbershop. We have a team at the barbershop to engage with men in a setting that they're comfortable with, do health screening, answer questions, and basically tell them more about what access is available in the community. That's just one example of trying to go where people are meet them and provide them the information that they need.
Jorge, that's a great point. I'm going to steal that from you. I'm going to try to reach out to our local barbershops.
That's great. Any other things that you've tried with community organizations or local stakeholders, Abhi?
Yeah, I mean, we have the traditional, PFACs, the patient family advisory group. We have a community advisory group as well. But I think the biggest success that we've had by engaging our community is, we have an OB program, and we started to see that our deliveries went down from about 3,600 to about 2,200 over 10 years. So there was a slow decrease. And we started to feel like there's something wrong here. Overall deliveries are going down, but not by that significant of a percentage. So we engaged the community, and there were close to about 12 or 14 hospitals that closed their OB programs in the city of Philadelphia, or around the city of Philadelphia, in the last decade, 2 decades, I believe. So if anything, we should have seen a number going up, or at least stable. So when we engaged them, what we found is, the true response that you don't provide the right services that we need. You don't have the right, in terms of infrastructure, not in terms of quality of care. The quality of care is great, but our infrastructure, if you look at our NICU, we have 2 rooms. We don't have individual private rooms. If you look at labor and delivery, we still had some semi-private rooms. So patients, and we've been talking about our populations, right? So these patients don't have the resources to leave the neighborhood and go elsewhere, but they had started to abandon us and go to other places because we weren't providing them the care that they needed. So that was very positive feedback. By chance, we bought the CTCA campus that was closing in not too far from us, about 3 miles from us. And we've converted that into a Temple Women's and Family campus. And we're going to bring in OB, GYN, an expanded NICU. We'll go to private, I think it's 36 private labor and delivery beds. So we'll be providing a lot more services to the community, and we're thankful to them for letting us know that that's where we were falling short, and which is why we were seeing a lot of our patients not getting their prenatal care, and we all know that infant mortality, maternal mortality is a very big problem in the Black and Brown communities. So I'm very, very glad that we were notified of that, and now we can take a step. We can move forward. We can provide better services. We'll have better connectivity. We talked about technology. We'll have some linkages with expecting mothers. So those are the kind of services I think that we'll be able to provide on that new campus. But again, thanks because of the community letting us know that that's a shortfall. The other thing, Peter, that we're really, really proud of is our community health workers. So we have hired a significant number of people from our community, and these are people who've been born and brought up in this community, who are friends, neighbors, and relatives of our patients. And so there's already that level of trust. So, we've been talking about take the care to where the patient is, but the second other thing that's as important as that is the trust level. So if there's a community health worker who who's knocking on your door, you're probably going to let them in than another person, from Temple coming in and telling you that I'm here to take your blood pressure or something. So the community health workers, we actually recognized them in our annual gala just a few months ago. So that's a spectacular group of individuals who've been able to serve about 2,000 patients, set up over 30,000 appointments for them over the last year. So again, all the feedback based on engaging the community, hearing them, and being able to deliver solutions that impact their care.
Wow. No, that's amazing outreach. Alpa, anything that you'd like to talk about?
I would. And, what I will say is I'll just pick up on the word that Abhi kind of stressed, which is trust. I think for me, one of the most interesting kind of evolutions of Standord's role in the community, because I will say over the years, our engagement in the community and their perception of our engagement, of the community's perception of our engagement, has kind of meandered. And so one of, I think, Standord's biggest opportunities came during the pandemic. How do we, as an academic healthcare organization, a community provider, show up in this time of need? And I think one of the, and this is my observation and connection to the work, which was our approach needed to be very different. In academic medical centers, there's a lot of cachet around the research and all of that, and that brand positioning can be very overpowering and potentially creating a lot of mistrust in the community. And I think our approach was really around, it's not about what Stanford's going to do out in the community. It's more of the backseat of how do we support the community partners that are there, because the trusting relationships exist within those community partners, those community providers, and where Stanford could come in was actually support through some of the infrastructure, some of the extended staffing in the vaccine clinics, for example. We had some of the resources that could turn around lots of medical kind of translation of education materials. So where were our strengths that we could bring to the community partners who had very strong relationships with some of the populations and communities that we wanted to help and support? And I think, ongoing through our community partnership programs, really lending our support to the agencies beyond what Abhi and Jorge talked about, but how do we lend our support and resources to the agencies that are there that really understand the needs and the opportunities within very specific communities and populations. Because as much as we are an academic medical center that has lots of wonderful talent and knowledge, we don't know everything, and we don't know some of the nuances around some of these specific communities that we can support kind of from backstage, I will say, versus being in the forefront, where sometimes organizations like ours like to be.
Yeah, Alpa, you brought up a great point with, we try to forget the last 3 years of our lives based on what we all went through, but you bring up a great point. If it wasn't for the community engagement, getting the vaccines to our communities, doing the COVID testing, all of that would have been impossible for our institutions. I think we heavily dependent on the barbershops, the churches, all of the others to try to get us in front of the individuals in the community. So yeah, great point.
Peter, if it's okay, I'd really love to jump on the trust bandwagon, because I think it's just an important component of really engaging with the community and being effective. And along those lines, I think it's so important that people really look at the workforce that they're engaging and creating. We really do strive to have a workforce that reflects the community. And we find that helps build the trust considerably, whether it's in our hospitals, our clinic, on our street medicine teams and department for engaging with homeless. That connection to the community is a significant tool to facilitate engagement and trust. And I was recently part of a panel interview for a diabetes educator, and I can't say it any better than this person. When they were asked, are you bilingual? And they answered, not only am I bilingual, but I'm bicultural. And that just says so much in terms of being able to understand and be understood with whom you're speaking with and engaging.
Right. And Jorge, why don't I start with you on this one? Because this kind of ties into what you were just saying. What advice, if you had to give 2 or 3 pieces of advice to an organization that was struggling to provide better access for their underserved population, what pieces of advice would you give?
Well, I would say, number one, understand your community. And understanding your community means a lot of different things. It means listening to your community, whether that be through just direct engagement, listening, paying attention to your patient satisfaction scores, having focus groups, doing community briefings, these sorts of things. But also, I would say understand your community through investment in data analytics also. Understand, what are the characteristics of those that seek care in your facility? And what are the characteristics of the population, which may require external data analysis to really understand that, because they may not be synonymous and often are not. And so having a better understanding of what's happening in the community as well as what's happening in your institutions with community members, I think is really key, has helped us considerably, and helps us to determine where are we going to focus and prioritize certain programs and initiatives. So those are my initial 2 points of advice.
Alpa?
Sure, maybe I'll build on the great points that Jorge already outlined, and maybe use a similar model of kind of the external and then the internal framing. I think, and I'll speak from the patient experience perspective, that a lot of what we have seen and is I think becoming even more clear, that the experience of the care team and those that work in the institution and the experience of our patients and families are intrinsically linked. And so when we think about what we as organizations can do, I think about the cultural competency piece and this notion of kind of patient-provider concordance, and where you feel comfortable is where there are people that are like you. And so to create even those trusting one-on-one relationships, I think the organizations can continue to work through strategies that bring those 2 points closer together. And I think there's a lot of conversation right now, and to me, even in my own kind of thinking and processing and where do we see patient experience evolving, and really looking at this intersection of DEI and health equity, right? And it's really getting, I think, to those points. From the external perspective, so I think building cultural competency with staff, raising that level of awareness is really important. The second part is the external kind of factor, and I'll go back to the community and community partnerships and creating the trusting relationships with those that have influence in our local communities. And I think finding the right ways to partner and engage, I have found very rewarding, and also ensuring that we bring the community voice into any of our planning work to ensure that we've got our voice of the community, in addition to the patient and the family, incorporated into the work that we're outlining for the organization.
Abhi?
Yeah, Peter, I mean, it's ours is very similar to what both Alpa and Jorge already covered. I mean, you can't put more emphasis on knowing your patient. So we've been talking about, social determinants of health. We have to understand what the limitations are of our patients, right? So I keep using this example. If a patient goes into see an endocrine and is pre-diabetic or diabetic, and they say, well, change your diet, and here's the medication, and they give you a script or a bunch of scripts and tell you, well, come back in 6 months and I'll see you. You don't know if that patient has, lives in a zip code that has a food desert. You don't know if they have access to fresh food or not. You don't know if they have access to get their medication. So I think taking that next step and making sure you know those patients is really important, because it's not only the care that we're providing, but it's the holistic approach of whether that patient can meet all of the other needs of their diagnosis. So, with that, we've created a food pantry, for example. I bring that up because, just like you mentioned, I came from my leadership meeting, and it was announced that every Thursday we now have a food pantry where we have been servicing our community. So that's great. We talk about clothing. We have clothes donations. We've in fact really proud of this. We've in fact tied up with Philadelphia International Airport, because there are a lot of lost luggages. Just think about it. We all know that, never connected that with going to them and saying, okay, when you're trashing these suitcases, please give them to us. So now we have two things. We now have clothes that we can give out, and we have bags that we can give out, because when we had only the clothes, people were walking out with a bundle of clothes in their hands or in a plastic bag. And now, there's better visibility to these patients when they're walking out. As dignity, right? They're walking out with a backpack or a suitcase or something like that. So we cannot emphasize on organizations that are struggling to please look out and know your patients. I think that's really going to be key, because we all provide great clinical care. It's the other stuff that you miss out on, which you have to couple with that clinical care to get better outcomes.
Great. I'm going to ask if there's any questions from our audience. I have another question to ask, but I'm putting that to our Wendy, do we have questions from the audience?
I actually do have actually several questions, but I'm going to narrow it. I'm going to narrow it down. And I do have one quick question first, and that's to the whole group. Are there any comments on, I mean, you're all in urban areas, but any differences or similarities on rural areas versus urban areas?
I mean, I'll go ahead and start. And you know, I have experience of working in big health systems, small health systems, and even in critical access hospitals in my past. And I do see some similarities. In fact, sometimes when I try to tell people the environment that I work in, I say, you know, actually, I'm in a critical access hospital type environment in one of the most populated counties in the country. And I say that because we have a deficiency and a shortage of physicians. We have a deficiency and a shortage of access to specialty care and high level specialty care. We also, there's an issue of distance or time spent in a car trying to get somewhere, which can be a significant barrier. When I was in the rural setting, not uncommon to have a patient drive 2-3 hours to go see a specialist. But you know what? In Los Angeles, at the wrong time, you may just want to go 15 miles. That could potentially be 2 hours in the car also. And these can be significant barriers. So I do see a fair number of similarities.
Mm-hmm.
Yeah, I think Jorge hit it. You know, so access, it doesn't really matter if you're rural, urban, no matter where you are. You know, right now access is, we're all struggling with access, right? There's a lot more demand than supply, which gets, you know, highlighted even further in a rural area, right? The specialist piece is really important too. You know, I talked about Temple having a transplant program. A rural hospital is not going to have those same high-end services. They may not have the same kind of radiation oncologic, you know, equipment that we have in most of our settings, right? They may not have ECMO. So those are the kind of things that I think rural hospitals are going to struggle a little bit more. But again, it keeps coming down to access. If we are able to improve access for our patients, no matter where we are, that'll go a long way. You know, if you don't mind, just to touch on that access piece, what we've been able to do is, because along with access, you have to have a close balance with burnout, right? There's less staff. There could be, if you have longer hours, there could be more burnout, right? So I know we touched a little bit on technology, but again, what we've been trying to do is to use technology to improve access with the same resources that we have. So 2 examples of those are, one's equipment and one's personnel. On the physician side, you know, we all use Dragon, we all use Siri, right? We all have started to embrace voice in our lives. So what we started to do is to have Dragon or Nuance, you know, have some dictations in the clinics so that physicians are able to use those things to dictate notes, to navigate the EMR. And believe it or not, in a year, that has created capacity that's equal to about 600 more patient visits. So it's the same physicians, same staff, and that's increased visits by about 600% or created capacity by about 600. The other thing is, and again, this can happen in rural areas too, where you can implement technology, is the use of AI. Mm-hmm. So our imaging centers were all 2-3 weeks, you know, out when it came to scheduling cases. We've again uncovered that there's AI and other pieces of technology that you can implement on machines, which makes, for example, our MRI machine 30% more efficient. So we're able to get those many more patients through our outpatient MRI settings than we were able to do before. So I think there's ways to overcome it. There's similarities in terms of our challenges, but there's also similarities in terms of our solutions, which we can actually transfer to other areas as well.
Thanks. And Alpa, do you have any thoughts or anything you'd like to address on that issue?
Abhi and Jorge covered so much. It's I would say I 100% agree with all the points. Maybe just one other thing to add. I think for general kind of patient population as well, health literacy is a challenge, and I think can be an equal or more challenge for some of our underserved populations, as well as I just think the pure act of navigating the system, whether it's navigating insurance or finding coverage or financial assistance, to once you get an appointment, if you're lucky to get an appointment when you need it, navigating, again, a super complex system that doesn't make it easy for patients in general, let alone underserved populations. So I think regardless of setting, I think some of those other issues prevail regardless of kind of geography or what have you.
Alpa, it's interesting you said health equity in all of our survey results. That was the topmost social determinant of health parameter that was flagged. We were expecting, transportation, housing, all of those were close, but health equity was the highest.
Wow. Thank you. So I have another question here, and I'll put it out to everyone because it wasn't addressed to any specific person, but it is. What policy changes do you believe are necessary or needed to help improve access for the underserved? And I'll put it out to all of you, whoever wants to respond to that.
I can go. I mean, so one of the main things that I think we all need support on, which has been in the news a lot, is supporting the 340B. There's a lot of proposed restrictions to that program. I'm sure Jorge and Alpa feel the same way that, Temple Hospital, at least I can talk about ourselves, we're the kind of hospital that 340B was created for. So I think from a policy standpoint, we have to keep supporting it. We have to make sure that it does not get discounted. Thankful to CMS that they revised some of those rulings that were put in place a few years ago. But without that, we're all going to struggle because the federal dollar actually goes a long way for hospitals like ours than some of the others. So really, when it comes to policies, we all need to stand together to help support that. The other thing I can think of, and I don't think we touched on it enough, is behavioral health, mental health, right? So that's become a very sort of a secondary diagnosis. And like I mentioned early on, about 50% of our patients have that. So again, we have to request policymakers and that, the providers that provide services for mental health get parity, they get adequate reimbursement. Right now, that's an area that does not get reimbursed really well. There could even be opportunities to, encourage people to go into that field, whether as physicians or mental health techs or, substance use techs or whatever that may be, by providing scholarships, by providing incentives. So I think those two come to mind that we definitely feel that we should focus on. One that's more focused on the provider and one that's more focused on our population.
Thank you, Abhi. Any additional thoughts, Jorge?
I would just add that from a policy standpoint, when we talk about the deficiencies in access for our community, at the heart of what leads to that for us anyway is the reimbursement model. We are very dependent on the state Medicaid reimbursement, as the vast majority of our patients are covered by Medicaid. California is number 42 in the country in terms of states for amount of Medicaid reimbursement. That leads to a 1,500 physician shortage in South Los Angeles. It leads to a significant decrease in delays in access to care, and an incentive model by not paying outpatient providers sufficiently. Is why we see much of the issues of chronic disease mismanagement or lack of management in our community. And just to highlight that, our most common surgical procedure that we perform is a lower extremity amputation. The community of Pasadena is only 20 miles from the community of Compton, which is in our area. But if you have diabetes and you live in Pasadena versus in Compton, your chance of having a lower extremity amputation is 5 times higher if you live in Compton versus if you live in Pasadena. And in Malibu, which is only 30 miles away, it's 20 times higher if you live in Compton than in Malibu. These are differences that are just simply zip codes and affluence that leads to these significant disparities. So the underlying crux of it is equity in the the structural equity that needs to be obtained in the reimbursement model.
Thank you. Well, I actually have like 7 more questions, but we're running up to the hour. So I'm going to ask I'm going to pick one of these. It's a good one to sort of wrap the session up, which has been so incredible. But and I'll start with you, Alpa. What advice do you have for healthcare providers who are working to improve access and how they can work with health systems and other parts of the community?
Well, I'm sure that there's lots of learning that we can do from the many organizations that are probably represented out in the audience. But I think I'll speak from my perspective. At least I think what has come into sharper focus, and it's probably reiterating several points that we've talked about. But for me, I think partnership with community is paramount, and kind of building on what Abhi had said, is like knowing our patients and knowing our communities, understanding the needs and gaps, and where we as organizations can help support. I think working on more creative and innovative ways to extend, and I'll put the word in quotes, access, because access can mean different things. And so whether it's technology, so leveraging telehealth, or even asynchronous modes of care. Again, this is that physician-to-physician consult model that I spoke to, and really thinking about how we can leverage the super specialized resources. And then I think the third thing is what I spoke about earlier, is how do you create the right culture and environment within the healthcare system to really create that culture of compassion, empathy, and inclusion, so people feel seen when they are being taken care of. And then maybe the fourth thing, just to kind of add to the previous question, whether it's policy changes or what we might aspire to in the future, is the continued funding of our FQHCs and, again, partner organizations, because they are often the lifeline to many of our communities. And then I think in the future, is there kind of this core set of services that every individual kind of has a right to access to, whether it be through the education, the really understanding the social determinants, as Abhi had mentioned, that there's a core set of services that every individual can have access to aspirationally. And then maybe finally, I think some things for us to think about is how do environmental factors impact access to care and overall health for individuals, whether it's through the environment or other influencing components that impact someone's health outcomes.
Thank you so much for that. I know we're bumping up to the hour here, but just to the group, any other thoughts, before we wrap this up? Okay.
Wendy, thanks for setting it up. This was a great discussion. I think we all learned from each other as well. So thank you.
Well, thank you all so much. This has been phenomenal. And I know that there's a lot of, there's a long road uphill here. But having leaders like all of you in place makes me optimistic, and really do appreciate all of your time today. And there's a lot of lessons learned here. And thank you so much for joining us today.
Thank you.
Thank you.